All right, so good evening, everybody. So, today's masterclass is on antifungal by Dr. Shiva. I will not take his full name, long name, because to me he is Dr. Shiva and me, Shiva. So, he's a professor at PGI and he's known to be working in mycology for a very long time, very passionate mycology researcher, and I don't think he needs more introduction than that. So, over to you, Shiva, for a very, I'm sure, a very engaging and enlightening talk.
Yeah. Thank you, Dr. Sonal, and I wish all the participants Happy New Year. And so I'm really thankful for the IAMM and Sonal for giving me an opportunity to share my experience on antifungals with all the postgraduates, supposed to be mainly postgraduates. I don't know any other participants are there or not. Just that's why I will keep my talk to the basic thing, uh, to the basic one. Uh, just a minute. Can you see my screen, Sonal?
Yes, yes, yes.
Okay, so I'll be talking mainly on an antifungal. So I've structured in such a way that all about what you need, all about the antifungal means. Mainly, first of all, you have to understand which are the fungal infection that is main concern to the public and as well as a microbiologist and as a clinicians. And the next thing is we know what are the available antifungals, and then what is the mechanism of action of this main mechanism action. I will not go into the details of this pharmacology and all. As a only microbiologist or clinicians, how much we need to know about the antifungals, just those things I will just cover. This is really basic one. I will tell you the mechanism of this one, and later what we need to understand is about the antifungal resistance. So that one I will cover it up, mechanism as well as epidemiology and other thing. And lastly, I will cover up with the newer antifungals. There are very promising newer antifungals that are there nowadays. So those things I will cover and wind up my this one. One thing I will not cover in this one is about the therapeutic drug monitoring, which is also very important. I thought it will become too long, so that's why these all the major things I will cover in my this one, and we will have some time for question and answer. So regarding fungal infections, you all know that so fungus is already a neglected one. So we should not neglect the fungus. Now you can see this is one of the warning like this. Many warnings have been given by the many things. Fungal is not only a problem for an humans, it's also a problem for environment as well as many of the animals or toads and these things they are getting extinct but because of fungal infection. So that's why many of them have moved out from an human mycologist and become an environmental mycologist or animal mycologist like that. Because for environment we have a lot of money, but for treating a human infection and giving in funds for the fungus, really, especially for the human beings, human fungal infection is really very less. So next, coming to an major risk factors for the fungal infection. You all know about it. I will not go this. Just in this particular slide, I am explaining you the major risk factors. For example, cancer. You see, these are the estimation of this one. 2 million lung cancer patients will have 1.2 million leukemia, lymphoma. You do have major problem of candidiasis, aspergillosis, and pneumocystis in these patients. In case of AIDS patients, you know, 1.85 million at risk now. of fungal infection. You can see all the infection can be there in case of AIDS patients. Whereas another lighter group, if you take, for example, TB. So in TB, you can see that TB, COPD, and asthma. So you have chronic pulmonary aspergillosis. Whereas in case of COVID, COPD, and influenza, so you have mainly this aspergillosis. I am not talking about diabetes mellitus and mucormycosis that we have a problem in this one. So along with that thing, we do have an allergic disease such as ABPA and fungal asthma, where we have a major problem with a fungal thing. So sometimes we need an antifungal there also, even for treating an allergic disease, fungal sinusitis as well as ABPA, allergic bronchopulmonary aspergillosis. So many of the other infections which we see in a normal people, that is without any immunosuppression, fungal keratitis is a major problem, especially in a tropical area. Tinea capitis or tinea infection in general is a major problem, especially in India. Mycetoma, chromoblastomycosis, porotrichosis are the major issues. So if you talk about the incidence, you can see Candida auris. I don't know how many of you have heard about Candida auris. Candida auris, once upon a time, we did not knew anything about Candida auris before 2009. And now we can see that in all over the continents, we can see this Candida auris infection. This is a very difficult to treat infection, and it is a multi-drug infection, Candida auris, as well as we can say that it is an XDR infection. All the classes, it will be resistant to all the drugs. Cryptococcosis, still it is a major problem, though we have seen the lesser incidence, but still in case of South Africa, as well as in India, and as well as in African countries, it is one of the major cause of mortality in case of HIV infected patients. Chronic pulmonary aspergillosis, again you can see the incidence are really very high in Asian countries, African countries, and also in case of Latin American countries. So about COVID-associated mucormycosis, it was mainly in India that we had an unprecedented upsurge of COVID-associated mucormycosis. So more than 50,000 cases was reported. We know that more than 10 times more than that patient got infected. And also in many other countries, we had COVID-associated mucormycosis. And also, if you can see that nowadays the major problem is vulvovaginal candidiasis. If you can see the incidence, really, it is really very, very high. So more than 4,300 per 100,000 population, means in the general population, the incidences of this vulvovaginal, especially this recurrent vulvovaginal candidiasis, is been a major problematic. So to treat all this infection, we really need an ideal antifungal. So what is an ideal antifungal? So ideal antifungal we define as it should be having a broad spectrum of activity, and it should be target specific, because it should not cause an toxicity on a human being. You know that both human as well as fungus, they are eukaryotes. In eukaryotes, that's why we do not have like antibacterials, we do not have so many antifungals. So we do have, because of the toxicity, very few antifungals are available. So minimal, it should have a minimum post toxicity. And also another important character is it should be an fungicidal rather than fungistatic. Fungicidal is it should lyse the fungus and kill it. It should not inhibit it, inhibits its growth. So inhibition of the growth means again the fungal can remain inside and then it may cause an recurrent infections. So we need an infective fungicidal agent. And we should also have, because most of the antifungals that we have is an delivery method is by injectable. IV formulation is there. Oral antifungal is the one that is the best suited, and also it should have a good absorption and other pharmacokinetics parameters to be used as an oral agents. So these are the 5 important characters that we search for an ideal antifungal. So really we do have an ideal antifungal or not, just with or you can judge about it after seeing these slides. And before going to an antifungals, you need to understand about the fungal structure, especially the fungal cell wall and fungal membrane and the nucleus, whatever it is. So these things are important because these are all the targets of the this one antifungals. So fungal cell wall, it contains both the, for example, you have a manoprotein. It can be in terms of an galactominin, or in case of Aspergillus, it is galactominin, whereas in case of yeast, it is an mannan, Candida and all. And beta-D-glucan, it's all the is present in all the cell walls. For example, except this Cryptococcus and this mucorales, all fungus contains this beta-D-glucan. So it is in very high quantity in case of an Candida. Chitin is present in most of the fungus, and that's also one of an important part of the fungal cell wall. And later we have a cell membrane. Cell membrane you have in many of the enzymes. For example, you have an ergosterol. Ergosterol is an important component of a cell membrane. And you can see that FKS1 and FKS2, these are the one which are all produces the beta-D-glucan. So this you should understand. Many of the antifungal will have an effect on this FKS1, and some will have an effect on beta-D-glucan, and some on this one, for example, cell membrane, and also some will have an on this one nucleotide nucleic acid inhibition. So coming to a mechanism of actions. So before going exactly to the mechanism of action of the antifungals, you should know that which are the antifungals that is available for the treatment currently. So the major group of antifungals, the major group, you all know that azoles and allylamines are the major group. So this is the one will alter the cell membrane, and then membrane synthesis will be altered by azoles and allylamines at different level. So we do have imidazoles. Mainly imidazoles means, for example, older one. It is mainly available not as an oral formulation or systemic one. It is mainly an topical agents, clotrimazole, ketoconazole, and miconazole. Whereas triazole is a major azoles that is used as a systemic agent, as well as some are on the topical one, like fluconazole and itraconazole, both are available as in topical as well as this one. And we do have voriconazole, posaconazole, isavuconazole, and ravuconazole. And next group is, and you all know about the polyenes, which alter the cell membrane. And then alter the cell membrane, we do have mainly amphotericin B. We have amphotericin B, again we have a different formulation like amphotericin B deoxycholate. Deoxycholate is not being used nowadays in the Western country. It is banned, and only liposomal has been used. But even in case of an Latin America as well as Asian countries, amphotericin B still is available, and it is begin and one of a major agent for the treatment. But amphotericin B, again, it is one of the toxic drug. I'm not mentioning in my lecture about the toxicity. Otherwise, amphotericin B liposomal will reduce and toxicity, and it is a wonderful drug to treat and this one. And earlier it was considered as one of an broad spectrum antifungal agents. You also have nystatin and nitamycin. Nitamycin mainly used to treat an ocular infections. So next group of an antifungal is an echinocandins. In echinocandins, we do have three major one. So caspofungin, micafungin, and anidulafungin. So all the three can be used for the treatment of many of this one. Where the target and all I'll be mentioning. Next is inhibition of the nucleic acid synthesis. This is 5-flucytosine and grizophulvin. So coming to an polyenes. So in polyenes, as I said, that polyenes mainly inhibit the ergosterol. It will cause an effect on a cell membrane permeability. Both it will cause an sequestration of this one permeabilization, and major causes it will cause an pore formation on the cell membrane, amphotericin B. So once the cell membrane pore formation is there, it will act on an ergosterol, and that produces an pores on the cell membrane. So once there is a pore formation, all the constituents of the cell wall will come out of the cell, because it will also cause the membrane permeabilization, and in that way the fungal cell wall, some fungus will get killed. So it is a fungicidal agent. That's why we call it as a fungicidal agent. Other mechanism of action of amphotericin has also been, but the majority is by pore formation. It is an ergosterol sequestration, and to some extent it is an oxidative damage also can occur. But the pore formation is the cell membrane pore formation is the main action of this one. Next, coming to an polyenes mechanism of action. So you can have polyenes, mainly ergosterol. Ergosterol, you should know that in an fungus and in a human we have cholesterol. whereas in fungus it is an ergosterol. That's why azoles has become a very, very important drug. So because azoles will not act on an cholesterol, so it will act only on an ergosterol synthesis pathway. So that's why it will be a fungal specific and toxicity has been reduced. So this is a method or an for that has been utilized for as an antifungals. So you can see the pathway is a very big pathway. So from a steroid biosynthesis or melanoid pathway, so you can see that. So lanosterol to ergosterol. So from different ergosterol synthesis pathway will be, it can be inhibited anywhere during this process of an ergosterol. So fungus required an ergosterol to survive. If ergosterol is not there, then fungus will get inhibited or it will be killed. So ergosterol inhibition is one of an important pathway for the inhibition of an fungi. So ergosterol pathway, anywhere where these azoles and terbinafine are the main drugs which acts as an ergosterol synthesis. For example, terbinafine. You have in ergosterol synthesis, before going to the action, you have in different enzymes, ERG1, ERG7. See, you can, these are all converting phanesterol pyrophosphate to squalene. It is ERG9. Squalene to episqualene, it is ERG1. So similarly, ERG6, CYP51A, CYP51B, ERG2, like that, many these things are there. The major one which we see is an ERG6 or CYP51A. This CYP51A or ERG11. You should remember these two things. This is the main target for an azole. Most of the azoles that is available. So in case of an molds, we call it as CYP51. Whereas in the yeast, we call it as ERG11. So anywhere it can be synthesized. If there is a mutation in this one, or if there is a mutation in CYP51, or CYP51 is directly inhibited, or ERG11 is directly inhibited, then it will just get, it will ergosterol will not be synthesized, and so there will be an inhibition. So in case of azoles, so again we do understand that you should know about the fungicidal and fungistatic. There are few azoles, for example, fluconazole. Fluconazole is considered as a fungistatic antifungal, whereas voriconazole, it acts as a fungicidal. In case of an Aspergillus, it is a fungicidal, whereas in case of an Candida, it may act as a fungistatic. So the voriconazole is a drug of choice for the treatment of aspergillosis, and fluconazole can be an fungistatic for most of the age. And see, for example, terbinafine. Terbinafine inhibits squalene epioxidase. Squalene epioxidase is an higher pathway. So after squalene, if it is not able to convert the squalene into further product, then the squalene is really become very toxic, and then fungus will get killed. So terbinafine acts by inhibiting squalene epioxidase enzymes, which will act at this particular level. Whereas in case of an other azoles, lanosterol, so it is an where it acts, so it will cause an lanosterol and toxic 14 alpha demethylestyrols in the plasma membrane, and it will become toxic and it cannot make further progress. So this is a main mechanism of action of different azoles. We also call it as an demethylase inhibitors. Again here these are all causing an demethylase inhibitors, all the azoles. So it is very important, especially to understand the resistance of Aspergillus to an voriconazole, which is a drug of choice. Next group of an antifungal is Echinocandins. Echinocandins, actually you know that Echinocandins acts on the beta 1,3 beta D glucan. 1,3 beta D glucan is one of the main constituent of the fungal cell wall. So you know that, as I said, so in Candida, in Aspergillus, and another fungus, one of the important component is 1,3 beta D glucan. Whereas 1,3 beta D glucan is absent, as I said earlier, in case of an Cryptococcus as well as in case of an Mucorids. So echinocandins do not have any action on cryptococcus or mucorales. In mucorales, only few mucorales they say that they do not have action, but recent studies they show that it may be having some action on even mucorales also, which causes me. So it acts based on an FKS1, FKS1, and these are the main thing, FKS1 and FKS2. So it will reduce the glucan content, inhibit these particular enzymes, and then it will reduce the beta-D-glucan synthesis, which is very important. In that way, all the three echinocandins will act. So next in this thing is 5-flucytosine. 5-flucytosine is one of another important factors. So you can see that 5-flucytosine enter the cell membrane, and then after entering by using an cytosine deaminase and other uracil phosphoridyl transferase, so this will get converted 5CFU, 5FC to 5FU. 5FU is a very active component, which is the one which mainly inhibits the thymidate synthesis and finally inhibit the inhibition of the DNA synthesis. So because 5FC, which inhibits an active action on a DNA, this particular drug should not be given alone. So there will be chance of a mutation and the organism can become resistant. So that's why they say that this should not be used alone. It should be mainly used along with the, it should be used, it should be along with the, any other antifungals for treating this particular infection. Okay, 5FC is one of the thing. And next coming to an grisofulvin. Grisofulvin again it inhibits an microtubule synthesis. So again it has got mainly action on a nucleus, microtubule aggregation by interacting with a beta tubulin and thus halts mitosis. So this is also an very important, but grisofulvin still it has become an important drug, especially for treating an this dermatophytosis infection in view of nowadays emerging resistance in the dermatophytes, especially due to this trichophyton endothelium. So grisofulvin, otherwise earlier it was one of the main first systemic antifungal that was developed, but still the only purpose it is a toxic drug. That's why it was not used in a systemic way, but now they are using it for systemic. So next coming to an development of a resistance with the antifungal. So you can see that as soon as the antifungals was developed, you can see different modes of mechanism of action of this one. Even you can see that the newer antifungals such as isobuconazole also has got when it got exposed to an azoles, this particular one, it may get resistant to it. So this is in just a table showing you the different mechanism. So one of some of the important one I will discuss in the future. So how we get an what are the different factors? Is it an azole resistance only that is important for this one? No, there are many factors that is important that you should consider when the patient is not responding for an antifungal agent. For example, host itself, immunosuppression, poor adherence to antifungal therapy may be some of the factors. Antifungal pharmacokinetics, the dose as well as tissue penetration. We need to have an antifungal to go to the place where it wants to act. So the tissue penetration is one of an important thing. For example, in case of mucormycosis and all, so because of necrosis, there will not be any blood circulation. Antifungal will not reach to that area. So that's why the treatment method here is you have to remove the source. Removal should be there. So all the necrotic area remove, and then later the area where it is still the infection, if it is there, with an acute where the blood vessels is reaching there, and antifungals are reaching through the blood vessels, and you should cover it up with an antifungal. So lack of source control is, that's why it's one of an important factor that will cause an clinical failure of an antifungal agents. So coming to an antifungal resistance in proper. So what are the drivers of an antifungals? So you can see this is one of the slide showing you a major drivers. So where all this antifungal resistance can occur. You can see like bacteria. So one of the major part of an acquiring resistance with the fungus is in the environment. So environment, there are many factors in the environment. I'm not going to it, especially for example, in case of Aspergillus and Aspergillus fumigators, Candida auris also, they say that it is from the environment, but still we do not know that most of these infections will be is present in an environment, and then some of them may get uh, resistance. Especially, for example, you can see fungicide residues that is present in an mainly in an agriculture. They use lots of fungicides. So I will come to it when I talk about the resistance to Aspergillus fumigatus, and whether within the patients can also there is and during the therapy may get an resistance. For example, this kind of resistance has been seen mainly during a therapy, for example, inappropriate one. So we can see in case of candida infection, so fluconazole resistance. So mainly because of an therapy, when the patient is exposed to an fluconazole, then fluconazole resistant candida can be a major problem in those patients. So, and also in case of Aspergillus fumigatus, it has been very well shown that during a therapy of an itraconazole therapy, when the patient is having taking a long-term itraconazole therapy, for example, long-term itraconazole therapy will be given in case of chronic pulmonary aspergillosis, or in case of an allergic disease like ABPA or fungal sinusitis. So during that time, this fungus that is when I inhaled, so those things can get exposed to a low concentration of this antifungal and get resistance there. So that's also there. So, and also nosocomial fungal AMR, once the patient is acquired this one infection with an resistant isolate, then from there they can spread it to, and these are the different major mechanism or the drivers of an antifungal resistance. So as I said, so this is one of an important mode, that is an use of an demethylase inhibitors. So you can see that these demethylase inhibitors, for example, azole resistance. The major thing is an azole resistance in an Aspergillus fumigators is mainly because of using these dimethyl inhibitors. These dimethyl inhibitors, azoles are not like an fluconazole, itraconazole, voriconazole, posaconazole. It is used only in an agriculture, and tons of it has been used in an agriculture. There the Aspergillus spores will get exposed to the concentration and lower concentration that is present in the environment, and it will become resistant. And those spores, when the patients inhale or a person inhales, that will be becoming a that will be resistant to an azole. So they will be resistant to all the azoles. For example, itraconazole and voriconazole, which is a major therapy for the treatment of aspergillosis, it will also be resistant. And even we can see to some amount the posaconazole resistance also can be developed. So again, you have a different resistance where it can be defined: microbiological resistance, clinical resistance. So clinical resistance already I showed you that, and also along with that, in this context, we need to understand about intrinsic and acquired resistance. So intrinsic resistance is the isolate itself, the species itself can tolerate a drug at an higher concentration which is used for the therapy. So that is called an intrinsic resistance. Whereas acquired resistance, as I said, from the environment or during a treatment for the patients, if it acquires, that is an acquired resistance. So you should understand this. That's why intrinsic resistance, if you know this particular table and more addition to it, so you can definitely, if you identify the fungus to the species level, so you will know that which all the drug you can give and which all the drug you should not give. So for example, intrinsic resistant trichosporan species. So it is an intrinsically resistant to assign trichospora, echinocandins. It is intrinsically resistant both this Cryptococcus and so, and also mucormycosis. So echinocandins should not be given in those patients. And also fluconazole. So you know that many of the species, Candida cruzi, glabrata, Incospicia, Trichosporan, Candida auris, earlier it was susceptible, but now it is all the molds where fluconazole does not have any action. Molds means, for example, dimorphic, it is dermatophytes and some dimorphic, this it may have action, but not major molds like mucor or Aspergillus, Fusarium, all are resistant to fluconazole. Amphotericin B resistance. You can see Aspergillus teres, Candida lusitania, Trichospora species, and Scedosporium species. So multi-drug resistance. Multi-drug resistance is the one at least resistance to at least one agent in two drug classes. And nowadays we see mainly these kind of resistance we see mainly with the Candida auris. So here, extreme drug resistance, XDR, all the three drug classes. For example, this Candida auris is resistant to all. For example, voriconazole, it is resistant. Amphotericin B, it is also resistant to caspofungin, but not 100% to all, but some percentage, and also it depends upon the clade of an Candida auris that is being seen. So antifungal resistance again, for example, Echinocandins if we come. So Candida is one of the major infection that we have. So what are the recommendation for the therapy of the Candida? I am not going into dose and other thing. So always you should think that most of the antifungals, the treatment when you give, it will have a loading dose. Before achieving a concentration in an this one blend, or expected concentration, so that's why we give an loading dose concept is there with all the antifungals, just generally all the voriconazole, fluconazole, posaconazole, echinocandins. So all they have. And so echinocandins are the drug of choice for the treatment of an candidiasis. So most of the, many of the, even recent one, there is no change. So any of the three echinocandin can be used in an, for the treatment of an candidiasis. Fluconazole is also having. So if you have done an susceptible one, the susceptibility testing, then fluconazole can be there. Otherwise, if you also have an data on fluconazole resistance in your hospital or setup, you can use that particular data and treat those species with the fluconazole. But initially, if you want to save the patient, so for if you have an blood candidemia, then patient should be treated with an echinocandin. And after doing susceptibility, if it is susceptible to fluconazole, and then you can change to fluconazole, de-escalate to fluconazole. So again, we do have an azole resistance, or as well as echinocandin resistance. It's very, very less compared to an azole resistance. See, you can earlier it was about 8.0 to 9.3, and nowadays it is increasing to some extent. So even this is an data from the Southeast Asia. So we do have an Indian study, if you can see. So this is one of an important study that was done in an ICU. So on all the Candida, so you can see that only 6.9% of them are resistant to echinocandins. Because Candida echinocandin is the drug of choice. That's why I'm talking about echinocandin resistance in Candida. So 6.5, and Candida auris, see, you can see that we could see that 9.5% of caspofungin resistance in Candida auris. And other studies in India also showed similar resistance. And also there are an elevated resistance to some of the species, Candida glabrata, Candida guillermonde, Candida rugose, and Candida fermenta. And most of the time, for example, azole resistance is lesser in case of Candida albicans, parapsilosis tropicalis. But the recent study, so our nodal center study and ICU studies, recent ICU studies show that Candida tropicalis resistance has been increased up to 15%. Even albicans, we do not have much of a problem. Parapsilosis resistance is also increased. But unlike Candida glabrata resistance in Western countries, we do not see much of an resistance to Candida glabrata. So identification to the species level of the yeast is very, very important. So this is an IAMM study, and these are the particular data. For example, azoles, you can see that this is a 28-7 center study. So you can see resistant 11.8% were resistant to azole. This is all for the Candida in an adults. And also you can see it is resistant even to voriconazole. That is expected. More to voriconazole rather than fluconazole. These are all major three Candida species. Itraconazole generally we do not use. Echinocandin, as I said, 6.9% resistance. Amphotericin resistance we do not see much with an in an Candida species, but we do see with other molds. So this is again the same data. Candida auris. So if you can see the split up of the Candida auris susceptibility testing. So amphotericin B, you can see all the different three classes of an antifungals. Amphotericin B resistance is 13.5 in an Indian clade, that is clade 1. Voriconazole 2.7% resistance. Caspofungin 9.5% resistance. So multi-drug resistance totally we could see in 12 isolates of a 901. So it is about this one. So coming to an Um, Again, this is an important data from an uh, uh, that on our own center. So again, we see a similar pattern, but this particular thing is just to highlight you that some of an important resistance. We are seeing amphotericin B resistance, Candida cruzi being resistant to amphotericin B, and also fluconazole resistance in Guillermondi, and also you have an azole resistance, that is Candida glabrata, Echinocandin resistance in case of Candida glabrata, Mecacamfungin. And see, in case of echinocandin also, if you are testing only one echinocandin, it may not be given reliable to other this one echinocandins. So you should test against each echinocandins in order to. So Guillermondi resistance to echinocandin is also very high. So Candida cruzi also is very very high. This is mainly from our center. But coming to an aspergillosis, again, triazoles is a major agent that is used for the treatment of an aspergillosis. For example, triazoles, we do have voriconazole, we do have itraconazole as a main agents, and now we have isavuconazole, we have posaconazole, and other agents. So in case of an Aspergillus, voriconazole is the generally voriconazole is an fungicidal agent in case of an Aspergillus fumigatus. So voriconazole is a drug of choice. Both itraconazole is also fungicidal. These two are the drug of choice for the treatment of invasive aspergillosis. Itraconazole, as I said, mainly it will be used in case of chronic pulmonary aspergillosis if you need for a long-term therapy, as well as in allergic disease, AFRS and all. Voriconazole, invasive pulmonary, as well as invasive other disseminated aspergillosis, invasive aspergillosis. And nowadays we are seeing a lot of problem with an aspergillus resistance. So here you can see that this was the first study that was done in an UK showing that so itraconazole resistant in an aspergillus fumigatus. And now we can see that you can see aspergillus fumigatus resistant to this one, especially as voriconazole or azoles, because of use of an demethylase inhibitors in a fungicide. So the percentage of an resistance, you can see that it's very, 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 very high. So in some countries, really it has become very, very high. In Netherlands, in UK and all, it has become very, very high. So Aspergillus, again, we need to understand the Aspergillus species causing an infection. So if you can identify, nowadays we do call it as an, in Aspergillus, we do call as an cryptic species within an Aspergillus fumigatus. You see that fumigatus is not a single species. So many species it has got. So for example, Aspergillus lentinus, so resistant to amphotericin B, itraconazole, and is also resistant to an voriconazole. And then posaconazole is a mainly intermediary one. So like that, if you can identify it to the species level, this particular table, if you can consider, see Aspergillus calcidoastus, it is in the astus group, and then you can see it is resistant to all the major antifungals that has been used. So, and also we do have some problem. This is, I'm not going into scedosporium, later I'll come. Another important resistance problem that is occurring, and it's all started mainly from an India. So it is a trichophyton mentogrophytes are interdigital. Now it is called an trichophyton indotiniae. So indotiniae, when you know all know that terbinafine is a major drug for the treatment of an dermatophytosis. Now, dermatologists have got a major problem in treating dermatophytosis because patient, even after taking a complete course of terbinafine therapy, which complete compliance and good quality, patient is coming back to this one as a relapse and recurrent. Patients are there for the 4 to 5 years straight with all the antifungals, but still it is resistant. But itraconazole somehow we have found to be a very wonderful and having a very good effect on this trichophyton indotiniae. And the terbinafine resistance was first time identified from our lab, and we showed that for this trichophyton indotiniae, we showed that mutation in squalene epioxidase was the major responsible agent for a resistance in this. Even in case of terbinafine rubrum, trichophyton rubrum, we can see this terbinafine resistant this one. So coming to a mechanism of antifungal resistance. So to understand major resistance pattern, So you can see that one of a major thing is you can see either an increased expression of an efflux pumps. You can either it can may not enter into the cell, or it may not bind to the cell wall, or the lower content of the target, or the target itself will modify because of mutation. So these are, and also biofilm formation will not allow the fungus, this antifungal to enter into or come in contact with the main fungi. So these are all the different mechanism of antifungal resistance in the fungi. So some of the important thing, azole resistance in the candida, if you take. So you can see that there is an altered sterol composition. So different ergosterol content which I was talking, and also you can see exogenous sterol uptake. So once the fungal flex pumps are being activated, all the fungus will, all the fungus, this one will come out of it. So even other activities, it will take up the sterol from other sources. And also you can see increased ABC transporter expression, increased MSFS transporter expression, and low affinity ERG11 affinity. For example, in case of Candida cruzi, because of that it is become an intrinsically resistant to Candida cruzi. It has got low affinity. So increased expression of ERG11. So in different this one, and also you have aneuploidy and mutations, isochrome mutation, heterozygosity, and these are all, I don't think for undergraduate the postgraduate which is much important, but still you can see that aneuploidy, isochrome formation, and heterozygosity are also another some of the important factor in causing resistance. Whereas in case of azole resistance Aspergillus, already I said main mutation is CYP51A mutation, and also a tandem repeats is there. CYP51B also is there, especially in case of Aspergillus flavus, we have shown CYP51B. And non-CYP mechanism of action is like in Candida, we have an increased expression of efflux pumps, mutation in some other gene, cholesterol import. Strips adaptation is another important factor that patient get resistant to this one. So whereas in case of an this one, as I said, the major cause of an this one is TR34 and L98H in an CYP51A gene. So here there is an TR34 mutation is the TR34 tandem repeats 34 at the promoter region of this particular gene, and also TR46 at this particular 46 this one has been added to it, and then there is this particular mutation in this region in CYP51. Majority 80% of the resistance are TR34 and L98H, and this is the second most common one. We also do this is again, as I said, it will all mainly it is driven by the environmental exposure of the azoles in the environment. So this is another complicated one. I am not going into details of it. So many other mutations, point mutations have also been identified in CYP51A, that is becoming a decreased affinity for the antifungal. And as I said, also overexpression of the protein. These are all already I have covered it. And so this is just telling you the what are the important mechanism. So you can see that most of them, if they have this mutation, TR mutation as well as mutation as well as tandem repeats, so it will be resistant to majority of an antifungals. Even other lower one, Y121F is also one of the one. This is mainly present in an yeast in ergosterol 11, but it has also been identified in case of Aspergillus fumigatus, and it is imparting resistance to one. So this is all environmental driven this one, and patient acquire infection through this. So in case of dermatophytes, as I said, the major one for terbinafine resistance is in squalene epioxidase, mutation in squalene epioxidase. So in India and Trichophyton indotinea, we are seeing that PHE 397 to LEU. Whereas in case of Trichophyton rubrum, so this LEU 393 PHE is the major one. So you can also see many of all these MDR drugs as well as PDR and MFS1. There is an increased drug effects in these things. Biofilm also it has been shown in dermatophytes, but it is not well studied in dermatophytes. And each shock proteins like overexpression of chaperones or strep adaptation, that's also another important mechanism. The major mechanism is a For terbinafine or allylamines, it is a mutation in squalene epoxidase, whereas in case of fluconazole, it is a major this efflux pump. This amphotericin B resistance, so very less studied. Again, amphotericin B, so you can see that it will have a different mode of as well. Either it can have loss of function, ERG11, ERG3, and ERG5, inactivation of this one. Majorly, it acts as on the ergosterol synthesis pathway. Sometimes it also increases the catalase activity in the cell. Echinocandin resistance mechanism. Again, you see the major one is as I said, FKS1 and FKS2 is a major important component. So there is an mutation in both this FKS1 or FKS2, either in FKS1 or FKS2. FKS1 mutation is the one which is most common. You have two major hotspots, hotspot 1 and hotspots 2. So it is majorly, we can see that FKS1 and hotspot 1 is the major one that we have a mutation that has been detected in many Candida species, which is causing a resistance to echinocandins. So in FKS2 mutation, we see mainly in case of a Candida glabrata. Otherwise, all other things you can see mainly in a FKS1. And even in case of Candida auris, we have shown that it has been we have shown in Candida auris also the recent mutation is an FKS1. Inadvertently, always this FKS1 mutation will be there. Whereas in case of this one, 5FC, so you can see that in 5FC, either you can see a mutation, it will not allow the entrance of this one drug, or either it may cause a mutation and binding will be affected, or you can see that I said that 5FC to 5FU should become. So if it is not converting to 5FU, it is an active one, then it will become resistant. So in all these different level, this 5FC resistance can be seen. So coming to a few words about antifungal resistance. Antifungal resistance, you have two standard method, UCAST and CLSI. And then you can see that nowadays different protocols are there, M27 for yeast, M38 for molds, M44 disk diffusion method. So major standard one availability is mainly we have a micro broad dilution method. So this is the major standard method of doing the thing. For disk diffusion, though we do have, so only for few antifungals they have given an breakpoints. So majority of the breakpoints are present for the yeast, as well as for few molds we have breakpoints, or else if we don't have an breakpoint for this is a document for a non-dermatophyte molds, so which is an approved one. So if we do not have any breakpoints, then you have to use an epidemiological cutoff value which will which will help in the guidance of this one. Most of the time for mold infection we consider this epidemiological cutoff values. So we do have different methods for the detection of an antifungal susceptibility testing. So as I said, so the broth dichlorobandylation method by CLSI or UPAST is a standard one. Sensitator is the next one, which is almost 99% to 99%. Now they do have both for yeast. Earlier only yeast they had. The latest machine we have both for yeast as well as they included few often molds like Aspergillus. And e-test really it is a very good test, but because it will become a really expensive one. Vitec one, if it is susceptible, then you can use this particular data from this one. Whenever there is a resistance, try to this one. My major issue is in Vitec, they do not have an, if you do not have, for example, if you do not have an identification to the species level, it will not give an susceptibility data for it. That is another thing. Some of the multi-TAF nowadays people are trying to do an susceptibility testing, but these are all still upcoming tests for determining an antifungal resistance in this one. So most of the time we do also have a genotypic method other than those things. So for example, mutation and all, we have to do an Sanger sequencing, and also we do have real-time specific primers, and we do have many of the genotypic methods can be used. Nowadays, the kits are also available. For example, some kits you can see it can identify from a clinical sample the organism by using a multiplex this one, as well as it can also simultaneously detect an antifungal resistance also along with that. So, and most often in-house methods are there, but kits are also available for detecting these particular. For example, Aspergillus multiplex kit, you can see here, it can detect an intrinsic resistance to all this particular resistance or mutation. It can detect just by doing a real-time PCR. So, mycogeny, it can also detect and resistance. For example, Aspergillus fumigatus resistance can be detected. So similarly, you have many kits that are available for identification of an resistance. For example, FKS1 and both in FKS1 and FKS2. So dermagenous, again, it can for diagnosis as well as again this squalene epioxidase mutation. This can clearly detect by using this pathognostic test, pathognostic kit called as dermagenous. Pneumogenous also, you know that this pneumocystis gyrovesi, they can be resistant to an um, clotrimazole, which is a commonly used drug, sulfur drug resistance, and it acts mainly on dihydrophthalate synthase mutation in this particular gene. And this particular detected gene mutation can be detected by using this particular. So we also have developed many systems for the diagnosis, and even this one we have developed for ARMS PCR, new methods, and isotype labeling. And these are all the recent methods that we have tried. And also you can see that directly from this one automated blood cultures, we can identify the resistance direct AFST by doing a direct AFST. So we have published this in Future Microbiology, and also by using a latest technique like Moldy also we can approach use this one. And lastly, coming to an latest antifungals. So you had this one antifungals. Now the latest antifungal is that isovuconazole. Isovuconazole really it has got a very good effect. So you can see the structures. So voriconazole is rounded structure, itraconazole it is an elongated structure. So there is a problem with absorption. So isovuconazole and fluconazole, you see, it is a rounded one structures. So absorption is really very, very good. We do not have issues with isovuconazole, voriconazole, and fluconazole absorption issue. The posaconazole, again, there is a problem. It's a long structure. So this structure also will give you some of an important feature of about the oral bioavailability and other things it can be there. Isovuconazole is one of that one, and it has been approved by FDA, especially for the treatment of an invasive aspergillosis, but few toxicity it has been there. I am not dealing with that toxicity. And you can see many of the antifungals, novel antifungals are coming up. Inbrexa fungin, fungep, phasmomogepix, opalconazole, orolofin. So some of them are going and for example, Inbrexa fungin. Inbrexa fungin, this is the only first orally bioavailable inhibitor of beta-1,3 glucan synthase. And you can see this is one of an important drug and FDA approved for the treatment of an vulvovaginal candidiasis. It is just like an caspofungin, but you can also give as an oral bioavailability is very good with this drug. So it can also act and very effective against an Candida auris. So just like an echinocandin, but does not act on these mucorales or cryptococcus because it is like an echinocandin, it act on a beta D glucan synthase enzyme. So next is an again it's you can see that the activity Aspergillus all the Candida it has got, but it does not have activity on mucorales and Scopuloropsis, Fusarium, Rhizopus and all. Variable activity with Schistosporium and Lemantosperm. If we have an activity on these two organisms, then usually it will be very good because these are the mainly most resistant organism and difficult to treat diseases or infection. So next is Phosmonogepix. Phosmonogepix, this is also another antifungals and you have both oral as well as IV formulation. The interesting thing about this particular drug is it has got an action on most of the drug. So and for example, this one you can see even Rhizopus, Aspergillus, Candida. So it is better than amphotericin B. So it can act on majority Lamentaspora, which is also resistant in case of amphotericin. Also we have a resistance to this Lamentaphora prolificans. So if I say that one of the most broad antifungal that is available that is on the pipeline is this Phosphonogepix. And also the additional feature is amphotericin, we do not have oral formulation. But this year we have oral as well as IV formulation. So in that way, it makes this particular drug as one of the important one. Risafungin again, it is just like an anidulafungin analog, so Echinocandins. But the thing is, it has got a long off life, so you can just give weekly dosing. Caspofungin and Echinocandin, anidulafungin, you have to take every day. So if you give 1 week therapy, it is almost non-inferior to the other this one. In the trial, it has been shown. So this is also one of an important drug, especially to treat an candida infection. Also, it can help in case of Aspergillus infection as well as pneumocystis jirovecii infection. So next is an encochelated amphotericin B. So this is an oral formulation it is coming up. So that's why it has become an like it is also having a less toxicity. So that's why it has become a very, very important one. Amphotericin B, mainly you know that complex problem is with that of an toxicity, and always you have to give IV. So that is a major problem. So this particular thing will really help in that way. So osteoconazole, again, this is another antifungal that is mainly approved for an vulvovaginal candidiasis. And the next important one is in PC9745. This is again osteoconazole that what we are talking. So it is coming up in the formulation of an as an nasal delivery. So if you give a nasal delivery, so especially in case of an chronic pulmonary aspergillosis and all, mainly they have developed for this one because it has got a very good effect of an Aspergillus familiatus, Aspergillus teres, and it is a very broad spectrum activity it has got having. So we also have evaluated and found that even it is having a good effect on Candida auris. So orolofim, again, it is completely different mechanism of action. It will inhibit the pyrimidine synthesis. So in that way, you can see that it is having action on most of the antifungals, but it is does not cover mucormycosis. Both IV as well as oral formulation is there. So in this way, it is really very useful for the treatment of invasive aspergillosis mainly, and also for this Scedosporium as well as Lomentospora infections. So this is just a table showing you. So in this particular thing, if you can see all these drugs, so Aspergillus, most of these have got an effective against this particular Aspergillus resistant also, and then difficult to treat disease like Scedosporium and Lamentaspora. At least we do have orolofilm and phosphonogepix, and also you can see that the extent of these actions, these phosphonogepix, you can see Candida, Trichospora, and also you have dimorphic fungus. It is effective against most of the fungus except this Candida krusei. So that's why this is one of the most Ibrexafungin. It may not act on this this one, but it is this Cunningham and all. But it is having very good effect on all the dimorphic also. So again, the last one is in super bioavailable. Hydroconazole, the issue is mainly with the absorption. They have come up with this different formulation, super bioavailable itraconazole, and it has got a lot of advantage over the conventional itraconazole. But it is really expensive and it is already there in the market, and people are using mainly to treat this dermatophytosis and also some of them chronic other infections. So with this this one, instead of giving an again conclusion remark for this broad topic, I'm just abruptly ending, and I think I have exceeded my time. And just any few questions if you have, I'll be happy to answer. Thank you very much for your kind hearing and listening. Thank you. So I will stop sharing now so that we can have an interaction and few questions. I'm not seeing chat box. Any questions are there? Hello, hello, hello. Any special points regarding antifungal drug or fungal infections or antimicrobial stewardship? Okay, that's a really very important thing. Points for an antimicrobial stewardship. So because when we want to start an antimicrobial stewardship, we are really in an infancy stage. But people are already talking about antifungal stewardship also. But that's why because before that we need to have a diagnostic stewardship. And also we need to train, that's what through and WHO what we are doing is we are giving training on how to conduct and how to identify the fungus, how to diagnose and pick up the fungus and do an antifungal susceptibility testing. So you have to do using a standard methods, and then you have to find out they have an epidemiology of this particular, at least for the yeast. If we start with WHO has started for an collecting a data for an yeast, especially for an candida. So with when we come out with this data, and we'll have some clue, and really it is a very important one. We should have an antimicrobial, antifungal stewardship also.
Thank you so much, Dr. Shiva. Very exhaustive, and I still can't believe it that you summarized it in 1 hour. It looks like a textbook. Thank you so much. It was must have been such a huge task for you to summarize everything in an hour. So thanks again. And I think I'm sure students have got a lot of insight, particularly to answer the antifungal questions which they get in the exam. So thank you once again. I don't see any other questions. There was just one which you've answered, and that's just your everybody's praising you for an very nice, elaborative, and exhaustive talk.
Okay.
Thank you.
Thank you, Sonal, and thank you everyone, all the listeners.